Good evening, everyone. I welcome you all for our fortnightly Meet the Expert webinar. And today we have a session on neuroimaging by Dr. Kish Mankar. I would request our President Shafali ma'am to introduce the moderator for today, the experts and speaker for today's session. Over to you, ma'am.
Yeah. Thank you. At the outset, I welcome you all to New Delhi next year to Yashabhumi, 16th to 20th September for Asian Oceanian Child Neurology Congress with the theme of innovation and insights in child neurology. And today, you must be wondering that it was not fortnightly. We had a session last week, but we are having a session this week to conclude this year before everybody goes on for the winter break. So that's why we have 2 consecutive weeks this time. So we have Dr. Kish Mankar, who is very well known. Can I have the slides, please? And he will be talking on various phenotypes and radiological correlates, neuroradiological correlates for the same. And I think it's going to be very interesting. And you have seen him with his series of sessions globally. So he's well known globally, very renowned neuroradiologist. He's consultant pediatric neuroradiologist and the clinical lead for pediatric neuroradiology at GOSH UK and associate professor again at GOSH UCL Institute of Child Health. And he has a lot of specialities on various aspects of pediatric neurology and has been awarded as the outreach professor in neuroradiology to Ghana by the World Federation of Neurological Societies. And he's authored 5 textbooks and 300 peer-reviewed publications. And he is a core member of the Brain Tumor Imaging Group and visiting professor to Sick Kids Toronto and University of Messina in Italy and founding president of the SPIN Academics for Outreach Education. Welcome, Dr. Kish. And for the experts, we have Dr. Biju Hamid, who we all very well know, and he's been very frequently coming and joining us. And Dr. Jem Kali, he's a head of neuroradiology section in the Egg University Medical Facility, Izmir, Turkey. He's currently Secretary General of Turkish Society of Neuroradiology, President of European Society of Emergency Radiology, and board member of European Board of Neuroradiology, Vice President and Treasurer of European Society of Neuroradiology, and really very experienced and has attended many international meetings and delivered hundreds and hundreds of lectures. I welcome you, Dr. Atin, who is a dear friend and colleague, and we have our weekly neuroradiology sessions with him, which are very exhaustive. And he's professor of radiology at All Institute of Medical Sciences, New Delhi, and his special area of interest is pediatric neuroradiology, and he has 276 journal articles and has given more than 220 guest lectures and has had a lot of orations and awards to his credit, including he's a fellow of Indian College of Radiology and Imaging and has had a lot of excellence and distinguished service award. Thank you, Dr. Atin, for joining. And we have the vibrant and dynamic young Dr. Nihal Reddy, who is consultant pediatric neuroradiologist in Rainbow Children Hospital, Hyderabad, and who is a pediatric radiology, he's done and neuroradiology fellowship from Royal Children's Hospital, Australia, and postdoc pediatric neurology fellowship from John Hopkins, USA, and he's Secretary General of Society of Pediatric Neuroimaging, SPIN, and he's a moderator for Pan India Pediatric Neurosciences session every Friday, and he's very dynamic. Thank you, Dr. Nihal, for joining. And for moderation, we have Dr. Our own alumnus, Dr. Harsh Patel, who's a consultant pediatric neurologist at the Zydus Hospitals, Ahmedabad, and honorary consultant and faculty of the postgraduate pediatric neurology fellowship in Ahmedabad. And he had done his DM from our place many years back. And he's a wonderful human being and a wonderful professional. Over to you, Harsh.
Yeah, thank you so much, ma'am. Thank you so much, ma'am. So I will invite Dr. Kish Mankar to go ahead with his presentation.
It's a general comment in terms of where the future lies. See, when we see patients with poorly controlled epilepsy, and then when we send them off for imaging, and then we will go and have a discussion with our neuroradiologist, the key information that we are asking our neuroradiology colleague is not just the possible gene which might be there, but more in terms of what the future is for this child, in terms of the prognosis, the functional outcome. Now, we've talked a lot about the novel phenotypes and genes, but what are your thoughts on in terms of the neuroradiology, using neuroradiology phenotyping for prognostication in terms of functional outcome?
Yes, Biju, we do this all the time, but novel phenotypes need a little more work because no one knows, even clinicians don't know what the natural history of these diseases is. And it comes back then to radiology in a significant way in terms of trying to establish studies that look at the natural history of these conditions. Because different kind of treatment options will be offered to these children anyways. But then going back or even prospectively setting up studies to look at the longitudinal changes, which will then dictate further counseling. Because when we talk about prognostication, we talk about counseling. But the theme today was novel phenotypes. And if we go back 5 years and pick up phenotypes from then and see how far we are, you will realize that there is still a significant paucity of literature, even amongst entities that we well know of, like the NBIAs, for instance, or even Alexander's disease. No one knows what the natural history is. And it is a great question because it calls for further collaborations amongst the multiple disciplines based here today, that we can't just do the one-off scan, make a diagnosis and move on. We have to have systems in place where we start looking at how they do clinically, what happens to their brain. Are they neurodegenerating, or are the treatments that are being tested on them, even as trials, actually acting in their best interests?
Because even the DIPTEC-5, the my understanding is that focal cortical dysplasias only constitute a very small number of children with DIPTEC-5, maybe like 10-20%. I think so. Like I will stand corrected if I'm wrong. So and also in terms of often the clinical features, the radiological phenotype often lacks the clinical features, isn't it? And by the time the pure radiological phenotype has set in, there's already changes has happened. And like, for example, if we, like the other day, we had a big discussion here in DOH on newborn screening. They're screening 700 genes, like whole exome, whole genome sequencing. So, and includes most of the developmental epileptic encephalopathy genes as well. So, you are, by doing the whole genome sequencing, you're already getting the answer. And then the radiological phenotype is happening later, like when we are, and also and these children have to be scanned multiple times, isn't it, in terms of as the disease evolves. And that often is a huge limitation for most of our children from different parts, isn't it?
We want to tailor imaging to as brief and as safe as possible. So my call out to all the radiologists there would be to not go around doing long scans. We could even get away with 2 sequences just to understand if the child is heading in the right or wrong direction, or is even stable. We don't advocate for imaging on a regular basis, but when there is deterioration, regression, and things like that, I think it's important to have that diagnostic modality done. And even then, the advocation would be to keep it as simple and short as possible. So you can see that in my entire talk of novel phenotyping, there was not a single spectroscopy or perfusion or DTI thrown in there.
Absolutely. And I think the key take-home point from what I got from your talk is exactly that, in terms of the sharing the data and fostering cross-border research and all these discoveries. Particularly like most of the cases that the case series that you have shown was the result of this outcome, isn't it? This data sharing, which is fantastic, and that's the key take-home for me.
Thank you, Biju.
Thank you, sir. Yeah. I would invite Professor Dr. Kem Khali for his expert comment.
Well, thank you very much for giving me the word. Well, actually, I believe that Kish made an excellent presentation. So, so we see that. Well, what I think that when I was listening to Kish, so as the radiologists, actually, now there are, the WHO 2021 classification and so on. So the geneticians and also the pathologists, they are doing these classifications. And then we are following behind. So this is what is happening. So because they say that this is a tumor, like Kish mentioned, the diffuse glioneuronal tumor with oligodendral-like features and so on. So then we come back So it comes out, and then what we are doing, we are just trying to find out what imaging findings can we find, can we see, can we describe to say that it is actually this. So this tumor. So actually we are following behind as the radiologists. So this is what I think actually.
I agree with Jem totally. But we have to
Dr.
also,
Kish, Dr.
Yeah.
Kish, if you've written something that you have an urgent call, right?
I know
So
there is something going on in the hospital right now, but that's okay. I
yeah.
think-
So no. I mean, before you, I'm just saying, before you leave, I mean, we have some cases where some Q&A, but before you leave, there's customary to give a take-home message. So you can just stop it anytime you have to leave, and wherever it is, you can pause and you just give your take-home message and go, right?
I
That's
can take the
custom-
call and come back and join this meeting again. That's the only
Sure,
thing I was trying to say.
Yeah. Thank you.
I'll do
Thanks.
that.
Thanks.
Thank you. Thank you, everyone.
Thank you. Dr. Atin?
Yeah, ma'am. So I would, of course, congratulate Dr. Kish for such a wonderful presentation. And as everyone has highlighted the fact that we need to keep our mind thinking. We see the findings, we describe them radiologically, we know what it is, but to think in terms of underlying genetic issues with that for a specific novel mutations requires for us to be constantly updating our knowledge, and that is best done as Kish described by a cross-border collaborations. If you see one case, if you've worked up, it takes time to work up a case. You often get the whole diagnosis a month or 2 3 months down the line. You make them, then you try and look for other cases, call your friends across the borders, and once you publish them, only then the community as a whole is going to get benefited out of it. And that's a very good take home message which I have also got, like Dr. Biju also said, from this today's presentation, that it is helpful to know what you are looking at underlying thing. And maybe I hope to maybe diagnose one of these in prospectively after learning through these very novel cases actually. Sorry, but that's what I'm still awestruck by the presentation.
Dr. Nihal?
Yeah, nothing much to add than what the speakers have already said. Fortunately, I have seen some of these cases which Dr. Mankad has presented. I think two important points I take over is, as he has mentioned, that he has not shown any advanced sequences or sequencing for these diagnosing these conditions. So I believe that the clinical phenotype or the clinical history presentation is very important for a radiologist to help in narrowing down the differentials for these diagnoses. For example, the case with the bigopathies, if you had seen the bilateral restricted diffusion in the central regions, that is the optic radiations, the internal capsules, and the globus pallidi, the differentials are vast. You can go up from ITPA mutations to mitochondrial disorders. We've also seen hypernatremias demonstrating these changes. Sometimes HIE also can be diagnosis. So once you see these images, and if the history is not provided, you always go back to your neurologist or your intensivist and check for these cardiac abnormalities, refractory seizures. I think those are helpful clues for the bigopathies. They especially also have elevated alkaline phosphatases and liver abnormalities, as far as I know. So that helps in narrowing down the diagnosis, also reduces the additional sequences, which might be more non-specific if you don't know the clinical history. So that is important. And as Dr. Atin has also mentioned, that cross-collaboration is important. Cross-collaboration between different radiological communities, also cross-collaboration between the clinical branches and the radiological branches is also important. That is why these meetings are very helpful on a radiological perspective and also on a clinical perspective. So yeah, that's it. That's all I have to add.
Thank you, Nihal. And I think before
Thank you.
Dr. Jem, once again, just wanted to mention that it's very important that we have, this is actually reiterating that we have been having neuroradiology conferences where the pediatric neurologist and the radiologist sit together and discuss the case, discuss their point blank. And that is what is very important. They have to be together to discuss. And Dr. Jem, please. you have
Yes,
something to
thank
say.
you very much. Just I want to say something. First, you are totally right, Professor Gulati. If you don't do the multidisciplinary meetings with the pediatric neurologists, as we are the neuroradiologists, so we will miss many things. So it is very important to have this communication, like we do with Hasan Tekkül, and now Erdem is going to present a case. The other thing about publishing. So I really a little bit hesitant about publishing because I saw a lot of papers that has been published, let's say 10 years ago. So some of them are now, we know that they were lies. They were not true. So because let's say we have a child which is 5 years old. So we send the child, normal child, nothing happens. We send the child to genetic sequencing. And then we find something with that child, but the child has nothing. So is that, let's say that child has medulloblastoma in the brain. So should we connect this medulloblastoma about this genetic sequencing? So we should be very, very careful when we publish something. Because if you go back, I'm sure in neuroradiology literature, when I go back to 10 years, I see that there are a lot of, I'm not saying lies. They believed that it was true at that moment. But now we know that it was not true. So there are a lot, I believe that also in your literature as pediatric neurologists, you also see that papers. When we are publishing, I don't agree with Kish that what we see, we publish it. What we see, we publish it. No, I don't believe that. You have to be sure what you are publishing. This is the most important thing. So that
so you have
we wanted to say.
Yeah, absolutely. But you have to have a clinical, radiological, and the genotype correlation. Then it is that. I mean, that is there. And I think it's important to publish. But yes,
Yes.
it is important to be sure of something and then publish. And that is there. I mean, that is definitely there. And doing collaborations cross-border is important. And like Atin has been doing with us neuroradiology for so many years. I mean, and even on his holidays, we keep sending him images, so that is why. And Nihal has made a network in India where, they don't have neuroradiologists in all the hospitals. So he does it proactively every Friday. So, I mean, that is really nice. Can we have the cases, Harsh? And can we just please stick to 5 minutes? So I think we have to complete on time. So Harsh,
Yes,
can you
ma'am.
please call?
Yeah, sure. So after excellent talk and this enriching discussion, we invite equally interesting cases. I would like to first invite Dr. Erdem Simsek from Turkey to present her case. And as ma'am has said, we have to stick to the time limit. We have only 5 minutes to present. Yeah, please go ahead.
Hi, good evening, everybody. Today, I will be presenting my case. Is it visible?
Yes, it is visible and you are audible. Yeah, please.
Okay. Hi, I'm Dr. Erdem Şimşek from Ege University Children's Hospital, and I'll be presenting a case called overlapping phenotypes in the context of suspected MS. This is a 13-year-old male patient who was referred to us after the discovery of new T2 hyperintensities on his cranial MRI, and these lesions raised suspicion for a demyelinating disease. His history included weakness in his right hand from the age of 6 months, and he had been under observation for an anaplastic astrocytoma, which was surgically removed. His neurological history had remained stable with no further treatment after chemotherapy for 4 months post-surgery, and he did not receive radiotherapy. Here are the images, and the cranial MRI findings revealed contrast-enhancing T2 hyperintense lesions in the left temporal and occipital lobes periventricular white matter. Here you can see the T2 flare and the ADC images, respectively, from left to right. And these lesions showed contrast enhancement on T1 imaging. Additionally, a lesion of ischemic gliotic nature was observed in the posterior region of the right ventricle. The patient presented with no significant complaints other than intermittent headaches. Importantly, there was no family history of demyelinating or rheumatologic diseases. Upon neurological examination, the patient exhibited a right hemiparesis, which had been present since childhood without any change. In terms of laboratory findings, the patient was negative for anti-NMO, anti-MOG antibodies, and oligoclonal bands. The IgG index was elevated at 1, and an NAA titer of 1 in 320 with a granular pattern was observed, which raised suspicion for an autoimmune etiology. The patient was then referred to rheumatology for consultation, and follow-up under rheumatology care was planned. On follow-up MRI, a new T2 hyperintense lesion was observed in the white matter adjacent to the left lateral ventricle, while the lesions in the left occipital and temporal lobe white matter remained unchanged compared to the previous scan. At this point, we turned our attention to the possibility of Sjogren's syndrome. An eye examination revealed dry eye, and a minor salivary gland biopsy revealed a lymphocytic focus score of 4. With these findings, the patient met the criteria for Sjogren's syndrome diagnosis. So it's important to highlight that pediatric patients with Sjogren's syndrome can present with neurological involvement, and it's most frequently in the form of headaches. These headaches can be migrainous, tension type, or non-specific in nature, as in our patient. MRI findings in pediatric Sjogren's syndrome are diverse, and the alterations often do not fit into a clear, well-recognized syndrome. There are two main pathways for the pathogenesis of these lesions. First is vascular, and the other is the demyelinating pathway. The most common abnormalities we see on MRI are white matter hyperintensities, usually located in the periventricular and subcortical regions. These white matter hyperintensities may actually precede the appearance of Zika symptoms, which makes them important for early detection of Sjogren's syndrome. Our patient had lesions with both demyelinating and vascular nature. So in patients presenting with T2 hyperintense lesions on MRI, especially when MS or other demyelinating diseases are suspected, we must consider autoimmunes in the differential diagnosis. Detailed history should include rheumatologic signs like dry eye or a history of rheumatologic disease or rheumatologic markers. And Sjogren's syndrome must be considered in cases with matching clinical and MRI findings. And we wanted to bring this case as it underscored the importance of thorough evaluation to differentiate autoimmune diseases from demyelinating diseases. That's my presentation. Thank you for listening.
Thank you for a nice case. Dr. Cam Khali, your comments.
Well, the case was very interesting because forget about the astrocytoma that the patient actually has been operated. But then, because of the astrocytoma, we were following the case. And what we see, demyelinating like lesions. And Erdem, can you share your screen again back? Because that I want to show you something. So demyelinating like lesions, and even at the follow-up, we have new lesions coming up. So we were thinking actually that this is actually a demyelinating disease like MS, or it should be MOGAD or whatever, or the other ones. But come back one more time. One more time. Come back. Come. Yes. No. Go forward. Yes. One more time. Yes, you see in the demyelinating lesions, in the post-contrast images, we usually see incomplete enhancement. So incomplete ring enhancement. So this case had incomplete ring enhancement. So it is very sensitive for demyelinating lesions. So we thought that this is an MS or any other demyelinating lesion. One more time, Erdem, just come one more time. Yes, stop here, please. No, come back. Stop. Yes, and also now a new for the MS patients. a new, for the demyelinating lesions, a new criteria will come up from my group, which is this, actually what you see here is the hyperintensity. It is not diffusion restriction. It is hyperintensity on diffusion weighted imaging. So to differentiate from demyelinating lesions from other non-specific hyperintensities and so on. So this is going to come up from my group. Now we are working on it. So it looks like, so this provides us the information that this is a demyelinating lesion. So we thought it was MS or the demyelinating disease, but then we searched as Erdem, can you go back to the literature that you showed? Literature at the end. Yes, because then we, yes, this one. So we understood that the Sjogren's disease may cause brain lesions in both ways. This is a very nice study in either vascular pathway, and the patient had old vascular lesions, or in demyelinating pathway. So actually this patient, with our imaging findings, which will be published, is in the way of a demyelinating pathway. But it's not MS, because the oligodendroglial bands or the other things that you are, as the neurologists, are looking, they were all negative. But the pathway, the other findings for, let's say, for the Sjogren's disease, they were positive. So it's very good that with the imaging findings, now we understand for this particular patient, the lesions that are new coming up, it's not MS lesions, but it's Sjogren's lesions, but not in a vascular pathway, but in the demyelinating pathway. So this was very interesting for us. So we wanted to present it to you, actually.
Thank you very much
Thank you so
for
much,
a
sir.
wonderful case and discussion. Any other experts want to say something? Dr. Atin, Dr. Nihal, anything?
So I have one question. So the anaplastic
Biju, yeah.
astrocytoma, does it have any association could you find, or it was just two different diseases in that same?
Of course, we didn't do any detailed genetic testing with both of them. But I believe that they were different things. Because we can never know. We can never know. In any genetic pathway, we still don't know, actually. In any genetic pathway, that the Sjogren's syndrome and the anaplastic astrocytoma may occur in, let's say, 1% of the patients. We don't have any idea about that. We don't have any information about that. I believe that because of that, because I don't have any evidence. So I believe that it was coincidence.
Right.
Also, in our
Thank you.
point of
Dr.
view,
Kumar.
the patient was diagnosed with anaplastic astrocytoma at the age of 6 months. That's not a common age for an autoimmune disease. So we also think that they are two unrelated diseases.
Thank you. Dr. Biju, you want to add anything? Or we can go to Dr. Biju?
The next case, yeah.
Yeah. Harsh?
Thank you. Yeah. So we invite our next case, Dr. Sugata Mahapadra from JN Medical College, Belgavi. Are you there, Dr. Mahapadra?
Yes, sir. Yes, sir.
Yeah, sure.
Yes, sir. Yes, sir. My screen is visible, sir. Hello.
You can go ahead, Sugata. Go ahead.
Yes, sir. So I'll be presenting a rare cause of neonatal leukoencephalopathy. I'm Sugata Mahapatra from JNMC Belgaum, with moderator being my guide, Dr. Mahesh Kamte, sir. slides. Yeah. So coming to the case, it's a 7-year-old female outborn child born to P2L1 mother via LSCS in view of previous LSCS with birth weight of 3.2 kg. Baby cried immediately at birth and was active and feeding well and was discharged from hospital on day 3 of life. Child developed poor feeding, fever, and refractory status epilepticus since day 5 of life, and the trial of IV phenobarbital, IV phenytoin, and IV levetiracetam were given. However, seizures were only controlled after starting midas infusion at 5 mg per kg per minute. The routine lab sends were normal. CSF analysis done. It was a traumatic tap, tried multiple times. However, only the culture and sensitivity could be procured, which was sterile. MRI brain done, which was suggestive of symmetrical T2 and FLAIR hyperintensities with areas of diffusion restriction noted involving bilateral temporal region, internal and bilateral external capsule, the corpus callosum, with few areas of glooming in the periventricular and peritrigonal regions on the SWI. So this was the MRI, and based on the MRI, like we got a consult for the MRI. So our differentials based on the MRI were first severe parental asphyxia. However, baby cried immediately at birth and was active and feeding well. So that was ruled out. Then second possibility was viral encephalitis, either enterovirus, paracovirus, rotavirus, or chikungunya, or neurometabolic causes like the vanishing white matter disease, the mitochondriopathies in the form of the LBSL, and the molybdenum cofactor deficiency. When we went for detailed GP examination, the general physical examination was suggestive of a macular hyperpigmentation over the nasal area. And when we asked the mother reported that those hyperpigmented areas were present all over the body at the time of after delivery, which had resolved over time. So this nasal hyperpigmentation was suggestive of a browny nose sign, and throughout the body, the diffuse hyperpigmentation was suggestive of chick sign. So we thought of chikungunya and we evaluated for further. So revisiting the history, mother told that she had a history of fever lasting for 1 week at the time of delivery without any focus, and mother's routine blood investigations and urine investigations prior to the delivery done were told to be normal. CSF that we had procured initially, we had sent for chikungunya PCR, which turned out to be positive, and serology tests, IgM sent for the IgM blood sent for the chikungunya that had come negative for the baby. However, mother's IgM or IgG testing could not be performed in view of logistic issues. When we went to the review of literature, we found out that vertical transmission rates during the peripartum period can range from 27 to 49%, and risk is higher when mother has high viral load at the time of breach in the placental barrier. So we went to the pathophysiology, and in the pathophysiology, the same thing has been mentioned, and this viral persistence in the monocytes causes inflammation with increased production of IL-6, IL-1 beta, and TNF alpha, and that is the cause for this inflammatory cytokines, and that impacts the neurodevelopmental outcome. In the literature, the most distinctive MRI abnormalities mentioned is in the white matter areas with reversible diffusion restriction, which is suggestive of transient ischemia with cytotoxic edema. There are two cohorts that has been published recently. One is the Chimera cohort study, and one is the Telechick survey. So Chimera cohort study and Telechick survey that had followed up the kids till 2 years of age and assessed their neurodevelopmental outcomes. And they have noted that around 50% of them have global developmental outcome, global neurodevelopmental delay in the Chimera study. And in the Telechick study, they have mentioned regarding the neuroimaging findings, where they have mentioned if we do MR spectroscopy, we can find low NA peak, especially localized in the frontal regions, whereby the coordination and language centers will be affected predominantly in these cases. Thank you. That's all my presentation.
Thank you for this interesting case. I invite Dr. Mahesh sir for his comments.
This was referred to us from the NICU for refractory seizure management. And as a part of workup of refractory seizures, we did MRI. And MRI showed this extensive white matter changes on the in the brain. And initially, before we could see the child, we thought of some metabolic insults to the brain. But when we examined the baby had this typical hyperpigmentation nose. It is a tick sign, and that took us to the possibility of chikungunya encephalitis. We could confirm by doing the serology here. Many studies have shown that there can be restricted diffusion in the white matter, but this extensive white matter changes going for cystic changes is not been described. And this MRI almost mimicked the possibility of vanishing white matter disease. So this extensive MRI has not been commonly reported in chikungunya, hence we thought we'll report this case. Thank you.
Thank you, sir. I invite experts for their comments. Dr. Biju,
May
Dr.
I?
Athene, Dr. Nihar. Yeah, please, yeah.
Yeah, well, I must tell you that I've never seen this disease before. So I'm doing neuroradiology for 30 years now, but still I've never seen this case before. So this remembered me the Zika virus, which occurred in the Latin America countries. So I've never seen it in my country. So now it comes that what Kish said, that we should share the knowledge within the locations and so on. So really, this was a very interesting and very teaching case for me. Thank you very much for the presentation.
Thank you. Thank you.
Very, very, very interesting case. So what happens to the, because initially I thought it must be dengue, but dengue doesn't, I suppose the pigmentation is quite characteristic of chikungunya, isn't it? What happens to the pigmentation? Does it eventually disappear once the child gets better? And what is
it will fade the time. It will fade the time.
And what is the pathology? Is it anything to do with the adrenal?
Not sure, sir. Not sure. It has been described even in the mothers also. Like in mothers also, they have described this sign, tick sign. So I'm not sure of the pathogenesis, but it's an interesting clinical clue for the case. Otherwise, we would have ended up doing some extensive metabolic and genetic testing and got stuck with some EUSs actually.
And how common is it? Because it is. It is not a neurotrophic virus, isn't it? Yeah.
No, it's rare. But this year there was an epidemic in Pune, Maharashtra. There are a lot of such cases actually. I had read the report there, and that made me think of chikungunya in this case. And luckily, I could confirm it, sir.
Interesting. Very interesting.
Thank you, sir. Thank you.
Dr. Kamte, just to add, over the last 3 months, I have seen 7 cases of chikungunya.
Oh, wow. Okay, fine.
All of them scanned in the acute stage, though.
Okay,
what was your? When was the child scanned?
Third week of life.
So our children were scanned within a week's time.
Okay, fine.
And they all have the typical pericovirus step pattern.
Okay, fine. Yeah.
So it's like an endemic going on, but I've seen 7 cases in the last 3 months.
Oh,
so maybe on the follow-up, these changes might turn out to be cystic changes, but the timing of the scan may be important though.
Correct.
So most of them get scanned in the acute stage. So we see those diffusion radiating pattern.
Yes, correct. Okay. Thank you.
Sorry, but what I could gather was you're trying to say that it was more like an antenatal infection, which had
it has to be during the delivery. Mother should be having fever during delivery, only then she can
during
the
delivery.
virus.
Okay.
Yeah. If she's infected before the delivery, then she'll not pass on the virus to the baby. So mother should be febrile on the day of delivery. Only then the infection happens actually. On the day or maybe a few days before the delivery, she should be febrile. So if she had a chikungunya before the onset of labor pains, then she may not infect the fetus or the baby.
And one more question I have, the blooming which we saw here, then that means could be due to some micro bleeds rather than calcification, because we are imaging it too close to the event. So they are likely to be micro bleeds. Okay.
Thank you.
Interesting. Very interesting.
Thank you, Dr. Mahapatra. Now we are moving to our third case. I invite Dr. Aishwarya from Chennai to present their case.
Good evening, sir. Is my screen visible, sir?
Yes, now it is visible.
Looking in the shadows, I'm Dr. Aishwarya, presenting under the guidance of Dr. Ranjit Kumar, sir, consulting pediatric epileptologist from Srinagar. We had a 12-year-old girl presenting with cognitive decline, speech regression, and seizures. Her past history dates back when she was 1 year of age. Child had suspected viral encephalitis. Organism was not identified, which led to intellectual disability, and the child was going to a special school. Child presented to us at November 2019 with lethargy, dullness, and slowly progressive encephalopathy with reduced speech output, left focal seizures. Neuroimaging done showed suspected inflammatory pathology. We treated the child with methylprednisolone and oral steroids, which showed only partial recovery. This was the MRI done at 1 year of age. We could see mild cerebral atrophy noted in the frontal region. A current imaging will be discussed by Ranjit sir.
Hi, Aishwarya, can you stop sharing? Yeah.
Yes, sir.
Is my screen visible?
Yes, sir.
Yeah, so this was the imaging and the presentation to our center. So I'm just showing the T2 axial images of the brain. So we can see there is a diffuse cerebral atrophy involving the entire brain, particularly the frontal regions. And there are T2 hyperintensities involving the bilateral frontal. And there is a kind of a significant T2 hyperintensity involving the gyral regions on the right temporoparietal region. So yeah, this was the imaging. And on contrast, so this one was showing significant gyral enhancement in the bilateral frontal region. And also there was a kind of a nodular enhancement involving the temporoparietal region on the medial occipital region on the right side. So this was the imaging at which the child presented to us. Yeah, go ahead, Aishwarya.
Yes, sir. Coming to the investigations, an LP was done. These are the basic cell counts we noted. The CSF HSP PCR was negative. CSF PCR for Burkholderia pseudomallei was negative. AFB was not detected. In direct smear, there were only occasional pustules with no organisms. We treated the child with IV methylprednisolone and oral steroids. In the MRI, we were able to localize a right temporoparietal occipital lobe expansile lesion involving the cortex and white matter extending to corpus callosum along with bilateral frontal atrophy. The differential diagnosis we had were tumor-like chronic granulomatous encephalitis, rare infections including neuromyelidiosis and other inflammatory pathologies. This was the child who presented to us in the pre-COVID era. The challenging decisions we had were financial constraints, COVID pandemic disrupting hospital services, chronic respiratory neurological issues, which posed a challenge for the anesthetist. The involvement of the multidisciplinary team was considered, and the major decision of doing a brain lesional biopsy for diagnostic confirmation was planned. This slide shows the brain biopsy of the gram stain of the lesion. The biopsy showed plenty of pustules, but organism could not be isolated. AFB was not detectable in the brain tissue. This was the eureka moment for us. We were able to detect HSV1 antigen in lesional tissue PCR. To confirm the diagnosis, we have sent the slides to AIIMS, neuropathology for immunostaining. HIV antibodies were strongly positive. Hence, we made the diagnosis of chronic granulomatous herpetic encephalitis in a child with post-encephalitic sequelae. I request Ranjit sir to lead the discussion further.
Yeah, so basically this child presented with a past history of encephalitis in the infantile age, and then she was a post-encephalitic sequelae, which resulted in intellectual disability. Then she presented again at 11 years of age with new neurological symptoms. So at that time point, this kind of a persisting lesion was there in the brain, and which was refractory to a course of steroid. So in view of persistence, we went ahead with the lesional biopsy. Actually, that was a tissue PCR, which came positive. The CSF HSV PCR was negative, And also the biofires and Burkholderia, everything was negative. So we discussed with Dr. Gopinath, who is a neuroradiologist in Chennai. He specifically thought of this entity. So that's the reason we sent the tissue for HSV PCR, which came positive. And then we reconfirmed with the immunostain at AIIMS New Delhi, which showed a strong positivity for HSV antigen. And then the child was treated with IV acyclovir for 21 days. And then we continued oral acyclovir. Now the child is on 5 years of oral acyclovir, and oral steroids were tapered and stopped. So I will just show you the post imaging. This is the imaging done last year. This was nearly after 2 years of the therapy. So we can see the brain has kind of again showing a diffuse atrophy, but the lesion seems to have slightly reduced, more gone into atrophic here. It will be better seen in the contrast image. So if you look at the contrast image, you can appreciate that the diffuse significant gyral enhancement pattern has significantly reduced, and there is a limited enhancement in the bilateral frontal, and which has shown a significant reduction. And the child is currently stable. I will just try to show the picture of the child. She's no longer having any active seizures.
Manjeet.
Yeah, just last slide. So we were thinking, why was the virus persistent for so many years and recrudescence and relapse kind of a situation? So we went ahead with the immunodeficiency workup, in which the whole exome revealed a partial Dye-George syndrome. So basically, this was a case of a partial Dye-George syndrome, which resulted in T-cell immunodeficiency, leading to a persistence of a herpetic virus, which resulted in a granulomatous kind of a encephalitis, which was persistent for years together. That's it.
Thanks for the amazing case. Experts, any opinions, please? Aishwarya, well presented. Any expert opinion? We go to the next case. First, next case, then comments can be taken in the end. Yeah.
Yeah, sure. So I invite Dr. Suthiraj from AIIMS Rishikesh to present his case.
Is my screen visible, sir?
Yes.
Yes.
So, good evening, everyone. Today, I will be presenting a case of intraventricular hemorrhage due to right choroidal AV malformation under the guidance of Dr. Pradeep Kumar Panda. Master B, who is a 13-year-old boy hailing from Meerut, UP, presented to our emergency with complaints of headache, which was sudden in onset, severe, starting in the occipital region and radiating to the front. It was associated with 4 to 5 episodes of vomiting, which was projectile, non-bilious in nature, and the child also had altered sensorium in the form of excessive agitation, not recognizing the attenders and not obeying commands. In the past history, the child also had complained of similar headache with altered sensorium 4 years ago, for which he was admitted in the hospital for around 10 days, and an NCCT head done at that time showed intracranial bleed. However, they were not having any old documents, and according to the history, he was managed conservatively, and he was discharged after 10 days with no focal deficits. In our emergency, the child had a GCS of around E2, V2, M3 with features of raised intracranial pressure. The child was immediately intubated and supportive care and raised ICP measures was given. Considering his past history and features of raised ICP, an emergency NCCT head was done, which showed hyperdensity in the bilateral ventricles, suggestive of intraventricular hemorrhage and obstructive hydrocephalus, for which we did a CT angiogram in the same setting, which showed nidus with abnormal vascular channels, as you can see here, in the choroidal region. Since the child was having hydrocephalus with raised ICP, and EVD was also placed, and after discussion with our neuroradiologist department, we did a cerebral digital subtraction angiography for the child. However, because of severe vasospasm in the bilateral ACS, the vessels were initially not visible, following which we did an intraarterial nimodipine injection, after which we could see tortuous vessels arising in the pericallosal area and in the right choroid plexus region. Here also we can see the tortuous vessel arising from the in the right pericallosal area. So following for this, the fetal arteries were identified to be from the distal branches of the pericallosal artery and distal branches of the PCA, where we had done an onyx injection, which was following which we did a check run, and it showed near complete occlusion of the vessels, as you can see here. Following the procedure, the GCS of the child improved to E3 VT M5, and we are currently planning to extubate the child. The EVD was also removed, and the child was currently having no features of raised ICP. So my take-home message is that in a child presenting with intraventricular hemorrhage, an emergency neuroimaging and a DSA will act as a roadmap, a vascular roadmap, and this will help in targeted interventions, and it will help in improving the survival and neurological outcome of the child.
Thank you, Dr. Pratik. Your comments?
Sir, only one thing I wanted to comment, sir. In such cases, we have to give intraarterial nimodipine also during the DSA. So in such cases, we should always think for the this triple H therapy, because there is associated subarachnoid hemorrhage also. So in this case, there are severe vasospasm. The neuroradiologist had problem while performing the therapeutic procedure. So that is one thing we need to keep in mind. So that we need to give nimodipine and this just giving fluids before the DSA procedure and other things. That is the one thing I wanted to convey in this case.
Thank you, Suthiraj. Well presented this time. Thanks. And can we have the next case, Harsh, and then we can have comments and final take-home messages, because we're already 14 minutes behind. Yeah.
Yes, ma'am. I invite Dr. Muskan Verma from IGICH Bengaluru to present her case.
All the presenters will mail their certificate by Asmita. She's not sharing on the screen because of time. Please.
Good evening, everybody. I am Dr. Muskan Verma, presenting under the guidance of Dr. Vaikund Raju sir. So this is a child, Aruna Kumari. She's 4 years female, coming from Raichur, and history given by maternal uncle. Complaints of fever 2 months back. It was high grade. Child was admitted on day 3, admitted for 2 days, given some supportive treatment. On the day of discharge, parents noted that the child had difficulty in walking. Initially, there was swaying, followed by in the next 10 days, child was completely bedridden with decreased speech output. Child was developmentally normal before that, used to speak sentences of 3 to 4 words, which decreased to the child not able to speak, and involuntary movements of upper limb, lower limb, and face in the form of head nodding, not able to pick up objects. This lasted for 1.5 months. After that, they noticed the child had fever, high-grade fever, with yellowish discoloration of eyes, with pain abdomen and vomiting and excessive irritability. The child was again admitted to the hospital for 5 days, received 1 PRBC, 1 FFP, and raised ICT measure, and was discharged. Post discharge, there was slight improvement as the child was able to sit with support, was able to recognize her parents. The child born to a 3rd degree consanguineous marriage, second in birth order. During this episode of jaundice with fever that the child had, her elder sibling also had similar episode of jaundice with fever with raised LFTs, and was managed on OPD basis. On examination, vital-wise, a child was stable, and weight was -2 to -3 standard deviation. Length and head circumference was also within normal limits. Head to toe, there was icterus present. On CNS examination, higher mental function, child was conscious, alert. Word output was nil, but the child was able to recognize her caretakers. Motor system bulk, there was symmetrical wasting. Tone was decreased, all 4 limbs. Power, upper limb was more than 3/5, and lower limb, hip and knee was 2/5, ankle was 1/5. DTRs were 1+, but ankles were non-elicitable. Rest, child had cerebellar signs in the form of head nodding, intentional tremors, no nystagmus or truncal ataxia. Per abdomen wise, child had a liver span of 10 centimeters, firm in consistency, and spleen also palpable, 3 centimeters, firm consistency. Other systems were normal. In this video, we can see that the child has a head nodding as well as intentional tremors of the hand. This was the previous hospitalization when the child was admitted with fever with jaundice. During that time, her HB was low, her platelet was on the lower side, and her PT-INR was on non-recordable. Child had received one PRBC and one FFP. They had come to our center after 20 days. This time, platelet initially was still low. It was 1,40,000. With OTPTs, initially her LFTs were also on the higher side. Her LFTs got better here. PT-INR was normal, but we still got a triglyceride done. Fasting was 320, ESR was 10, LDH was 337, ferritin was 189. Child was HIV IgM positive. TMS was normal. Fundus showed bilateral optic atrophy. NCS showed motor sensory axonal neuropathy, both upper limbs as well as lower limbs. This was the MRI that they had done during the first admission, showing flare images with hyperintensities, white matter hyperintensities, along with periventricular intensities, with T2 images also showing asymmetric involvement of the cerebellum. We repeated the MRI when the child had came to our hospital, again showing these hyperintensities in T2 as well as flare as well as diffusion restriction. DDs after imaging were MLD, mitochondrial, and HLH. MLD points and fever was there were symmetrical hyperintensities, periventricular and central white matter, but against there was asymmetrical involvement of the cerebellum. Mitochondrial, the history was still suggestive, but points against were there were no deep gray matter hyperintensities involvement. And HLH point in favor was there was diffuse white matter changes in cerebrum and cerebellum, but there was no cerebral atrophy or bleeding lesion. We did a aryl sulfatase level, which was negative, which was normal, and VES, which showed HLH familial type 2 perforin mutation, homozygous. So our diagnosis was febrile illness, nutrigression with quadriparesis, with aphasia, with white matter involvement, with cerebellar involvement, with bilateral optic atrophy, with motor and sensory neuropathy, with hepatosplenomegaly, secondary to familial HLH with hepatitis A positive. So presenting some more cases that came with HLH, CNS HLH to our center. This child was 5 years old, came with complaints of ataxia and seizures. With the MRI showing hyperintensities in the white matter, we first suspected ADEM, started on steroids. On tapering steroids, child had ataxia again, given treated as recurrent ADEM. Post that, child again on tapering steroids again developed ataxia, but this time she had systemic involvement, did a bone marrow, which showed hemophagocytosis, and it was Epstein-Barr virus.
Can you wind up? Peter, can you wind up?
Yes, ma'am. And then this was another case with the Shedaic-Higacy positive child, also with pancytopenia. And one with a 1-year-old female, 3rd-degree consanguineous marriage with developmental delay, with organomegaly, upward gaze palsy, nystagmus ataxia, with infantile spasm. This child also, MRI showed asymmetrical white matter hyperintensities. VES showed familial HLH. So take-home messages is primary HLH may present with first neurological manifestation ranging from 45 to 75% of the cases, and then they present with systemic features. So a high index of suspicion should be required for diagnosis if there is a relapsing course or partial response to immunomodulatory drugs or hemorrhagic involvement. Then these are good pointers to diagnose HLH.
Thank you, Raju. Thank you. Well presented, Peter. Raju. Yeah.
Yeah, this child, usually this child is a lot of confusion picture was there. Initially, even though there was a fever was there, but child again developed hepatitis A infection, and unusual findings are neuropathy was also there. Very rarely described neuropathy in HLH. So MRI it looked like a leukodystrophy pattern. Other than cerebellar involvement gives some clue. And child again during follow-up persistent hepatosplenomegaly that clinches our diagnosis HLH. And genetic was confirmed. So primary CNS HLH can present without peripheral nervous system, peripheral CNS involvement like hepatosplenomegaly and pancytopenia can be absent. So criteria may not require all the time to diagnose primary CNS HLH. So this should be considered as it is a treatable condition. Thank you.
Thank you very much, Raju. All cases were excellent presented. I will now request experts to make any comments on the last three cases and give the take-home messages, please. Dr. Biju.
All interesting cases, Dr. Shefali, and excellent session. So in terms of take home message, like I said, radiological neuroradiology phenotyping has got a very key role, and I think in terms of the future, personalized therapy, preventive therapy, and also predictive therapy, and that's where like correlation of the imaging phenotype with the clinical profile and the genetic profile will come. I mean, it's already we are doing that, isn't it? In terms of like imaging of SEGAs or like imaging in Parkinson's for tailored therapeutic approaches. But I think that's where the future is, and as Aishwarya and Ranjit's case, that longitudinal imaging phenotyping is also important in terms of assessing that disease progression and the treatment efficacy. That was a very good example. So I think that's where the future lies. And we also talked about basic imaging, and there is no need for advanced imaging. Perhaps there would still be a role for advanced imaging in terms of like in Parkinson's, DAT scans, and etc. So I mean, there is still a role for advanced imaging, but I agree that like artificial intelligence, machine learning, etc., might be a bit too hyped when it comes to pediatric neuroradiology, at least, because of the various subtle and overlapping phenotypes, and it would be very difficult to get these data sets in place for AI to help with these things. So you still need excellent neuroradiologists like we have. And I think there are still a huge shortage, and the key aims would be to upskill and train more and more of these excellent neuroradiologists to help us clinicians.
Yeah, and you very rightly said, and in the future, yes, AI will be helping. But one thing I wanted to say, like with the Ranjit's case and all, one should remember as clinicians that it is much more commoner to have atypical presentations of common conditions rather than having exotic conditions. We should always think, like in India, we have to think about atypical.
Raju's case and
Raju's case also, yeah.
Aishwarya,
Yeah.
was excellent cases, yeah.
Yeah. And that's why, we have to keep in mind, neuro TB can come anywhere in our country, in any form, any shape, size. So like any infections, and even the chikungunya,
Absolutely.
Mahesh, I mean, so that is something there. Dr. Jem?
Well, I must say, first of all, I must thank you all that it was a great discussion. I also myself learned a lot of things. Thank you very much. So this meeting shows actually the importance of making these multidisciplinary meetings. This is the most important thing. Without you, we are nothing. Without us, you are nothing. So you understand me. So it's very important.
No, but together we can rise and shine. Yes.
Yes.
And the idea of these webinars. Yeah, absolutely. And the idea of these webinars are having experts from different resource settings for understanding how we can handle. And that is something that was what my vision was. So Dr. Atin, our partner in crime for so many years.
Yeah, all of them excellent cases, and of course, radiology did give a clue, but what has been outlined was it is the clinico-radiological and often the biochemical or the lab which helps us. We have to think what all lab or biochemical parameters you have to check. That is done in the multidisciplinary meeting. You decide, okay, these could be the possibilities, so we have to investigate. You cannot be investigating like a open territory. You have to be having a tailored or a step-by-step investigation, like the case shown by Pratik's team in terms of a recurrent hemorrhage in the same location in a child years apart. So let's say child presents with a focal bleed. The question often asked us is there underlying something? But first we need to rule out step by step. There is no coagulopathy. There is no other cause for bleed. Then you might want to investigate for underlying lesion, maybe at the first time itself, after you've ruled out the clinical or the blood causes, you want to rule out underlying vascular malformation. But if you have not evaluated at that time, if there is a recurrent bleed at the same location, it is a very strong radiological clue that you have to look for underlying vascular malformation, maybe by a CT angio or by MR, or if in certain cases required, even taking help of a diagnostic DSA if there are like cryptic malformations to look. But if there are at different locations, then we have to think whether or not we're thinking in terms of a multifocal malformation, or maybe there is some underlying other etiology, maybe vasculitis, which is leading on to bleeds in different locations. That's how radiology helps to guide further even investigation steps, not just management also.
Absolutely. But the pediatric neurology people should understand and remember your history taking and examination are cornerstone. You can't be just blindly going on trying at investigations, and you can't start with neuroradiology and all. You have neuroimaging and anything. You have to have your history and examination place. You have to have a thought process so that you have sequential investigations to substantiate or refute the possibilities in sequence of your possibilities. I think that is something important. It should not be saying that anybody comes, you just do an imaging, and what is happening is MRI, whole exome sequencing. Now it will be MRI and whole genome sequencing after some time, and then you have this VUS and you are struggling, and then they come and ask you, and then you keep seeing, and then you see, and it is all that vicious. I mean, it's not vicious, but it is confusing circle. You go around, right? So you have to have a focused, thought processes. Thank you, Atin and Nihal.
Dr. Safa,
Dynamic.
thank you.
Yeah,
Thank you very
dynamic,
much.
Nihal. Yeah.
Not only neurologists, radiologists also need to have a more focused approach, clinical history and all that. Otherwise, we are all lost. No blinded reviews, peer reviews here. Just 2 comments on the case of granulomatous herpes encephalitis, possible mimicker for demyelination. The enhancement pattern is very different for what we see in a demyelination. That could have been a clue. And Dr. Raju's case, usually the histocytic spectrum, the T1s, if you see, they're usually slightly hyper intense. If there are some histocytic signature over there, usually the leukodystrophies are more hypo-intense on T1s. So the cerebellum also is a clue there. So yeah, those some subtle imaging clues may be helpful, but overall the clinical picture has to be kept in mind. And these cases highlight the importance of the multidisciplinary team meeting.
Thank you. Thank you so much. Mahesh, you want to say anything?
I think a wonderful lecture and very good cases.
Harsh, you were moderator. Anything you want to add?
Yes, no, it's a very learning session. So thank you.
Yeah, thank you, everyone. Our team still extended the time, although I requested them to stick to 5 minutes. But I think, anyway, it was a wonderful presentation, wonderful session. And I think Kish couldn't join. He had a call from the hospital, so that's okay. But it was a wonderful session. Thank you all for joining. And I invite you to come to New Delhi next year, September, for the AOCCN. And we would have newer, the topics are going to be all innovation and insights in child neurology. Registrations are on, abstract is on, submission symposia proposals are on, and we'll be getting you the proposals for, for the video challenge and the quiz shortly. Thank you so much for joining. You want to have the video in the end when people are logging off? Yeah. Thank you so much.